The students from SGPGI Lucknow, are you ready?
Good morning, my respected teachers, my dear colleagues. We from SGPGI, we are presenting a case.
Your name, doctor?
Sir, Dr. Smarak Ranjan Raut. And along with me, Dr. Amrendu and Dr. Ritesh are there.
Have you started screen sharing?
Yes, sir, already started, sir.
Okay, you proceed.
Yes, sir. Our patient, 34-year female, married, Hindu, from Raebareli, Uttar Pradesh, housewife occupation. She presented to our OPD with chief complaint of dyspnea and exertion for last 8 years and chest pain on exertion for last 1 year. So, on elaborating her present illness, she was apparently well 8 years back when she developed distortion. Initially, it was NOHA class 2, which progressed to NOHA class 3 for last 6 months. Dyspnea and dilated with cough, expectoration, hemoptysis, or seasonal variation. There is history suggestive of paroxysmal nocturnal dyspnea for last 6 months. There is a history of orthopnea, leg swelling, or abdominal distension. She also gives history of since last 1 year, which was suggestive of classical or typical angina, and which progressed to from class 2 to class 3 for last 3 months. Chest pain is associated to dyspnea, and there is no history of palpitation and syncope. She is not a known diabetic, not a known hypertensive. There is no history of prolonged fever. There is no history suggestive of focal neurological deficit. There is no history suggestive of cyanosis or recurrent respiratory infection in her infancy or childhood. In past history, she gives history of fever and joint pain associated with swelling involving specifically the ankle and knee joint, which was fleeting in nature at 12 years of her age, for which she was prescribed some oral medications and received intramuscular injections, which is remembered as Benadryl. There is no associated history of shortness of breath during that illness episode. She took that injection of Benadryl for 2 weeks. No history of hospital admission for breathlessness at rest or receiving any IV drugs. She is vegetarian and her bowel and bladder habit are normal. On treatment history, she is now at present receiving diuretic, beta blocker, and oral penicillin G, that Pentits, for last 3 years. She's obstetric history. She is married for last 12 years, having 2 living issues. The last childbirth was 6 years back. Both the children the delivery was uneventful, and institutional delivery was there. There is no cardiac ailments in her siblings, and she used to stay in a kacha house before her marriage, which is overcrowded. And at present, her socioeconomic status is in class 3. So to summarize my history, 34-year-old lady presented with insidious onset, gradually progressive dyspnea and exhaustion for last 8 years, which was progressed to last 6 months, associated with history suggestive of PND and history suggestive of typical angina for last 1 year, with history suggestive of rheumatic fever and anti-rheumatic prophylaxis, with no history suggestive of any bad obstetric history. So, on the basis of my history, I kept these are my differentials. First, I have kept valvular disease likely to be rheumatic and predominantly left-sided stenotic. Second differential I have kept as hypertrophic cardiomyopathy, dilated cardiomyopathy. Then lower down in the order, ASD or ASD with acquired that is MS, that is Lutenberger syndrome, or aorta arteritis. And lastly, I have kept idiopathic pulmonary hypertension.
So, on the basis of your history,
Yes, sir.
rheumatic heart disease on the top and left-sided lesions.
Yes,
Which
sir.
left-sided lesion you have thought of first?
Sir, mitral stenosis, because of sir history of PND is there, and the duration is quite long of this.
Had she any pregnancy?
Actually, sir, she was diagnosed in her second pregnancy, that is 6 years back. During that time only, she was having dyspnea, but she didn't require any hospitalization for that. That is only class 2, according to her.
Dr. Smarak, see, you have loaded many differential diagnosis this thing. You have load,
Yes, sir.
because it has to be relevant to the history. Okay, you
Yes,
have, this is a patient who had a typical history of joint pain, and of course, it is a rheumatic heart disease on Penidur long-acting penicillin prophylaxis. So,
Yes, sir.
what made you to think, I mean, in that order, hypertrophic cardiomyopathy, dilated cardiomyopathy, aortoarteritis, and idiopathic pulmonary artery hypertension? Because even if you make a differential diagnosis list, it should be a little relevant to the history.
Yes, sir. Yes, sir.
So, what
Yes,
made
sir.
you to think? See, this patient is having symptoms for last 8 years, right?
Yes, sir. Yes, sir.
So, what is the natural history of dilated cardiomyopathy?
So dilated cardiomyopathy, actually, sir, it depends upon the in which NOH class patient is. Sir, 80% means the 80% people will die by 10 years if the patient is in NOH class 3 to 4. So in this patient is having a NOH class 2 symptom for a long duration. So can keep as a differential, but angina is not so classical for dilated cardiomyopathy.
Can fit dilated cardiomyopathy into that. And what are the usual clinical presentation of ASD with Lutembacher? You just tell us
Yes, sir.
the symptoms. How does isolated mitral stenosis will present? How does
Yes, sir.
Lutembacher syndrome present?
So isolated MS will present with the feature suggestive of PVH, that is a PND, and basically dyspnea with orthopnea might be there. And if the patient is having Lutenbacher, that is ASD MS, so palpitation will be the predominant symptom.
See, palpitation is
Yes,
a
sir.
predominant symptom in an ASD Lutembacher.
Yes.
Why there will be a palpitation in ASD Lutembacher much more than in a regular, straightforward, isolated ASD?
So there is the shifting of the blood from left to right, the will be much more. The shunting will be much more in the presence of a metal disease.
The other thing
So that will cause increased volume of blood of the next.
Okay,
Yes,
that
sir.
means they will invariably, they will have a very torrential left to right shunt. Okay. See, what is
Yes, sir.
surprising in this case is typical angina. You said chest pain, it increases on exertion. So,
Yes, sir.
how do you explain a typical angina in a patient of, according to you, it is a rheumatic, most likely mitral stenosis?
Actually, the patient might be having another valvular involvement, more
Right.
likely alveolar obstruction, or sir, is so if it is severe age, then also we can get angina because of RVH.
Okay. No,
Yes,
you are
sir.
suspecting an associated aortic stenosis based on the symptom of angina, or is just atypical chest pain?
So it is typical chest pain angina what the patient has given the history. So it is associated MS.
It may not be in this case. Can you get a typical angina in a patient with severe pulmonary arterial hypertension?
Yes, sir. Can present, sir.
How? What is the mechanism?
Sir, severe pH will lead to RV hypertrophy. So increased demand will cause RV ischemia. That might cause angina.
Can pulmonary arteries compress the coronary artery?
Yes, sir. That might. Yes, sir.
How?
So if we dilate.
Which part of the coronary artery?
Sir,
Which part of the
yes, sir.
coronary artery?
Sir, left means left hand, sir.
Left?
Left main, yeah.
You mean left main, right?
Yes, sir.
Okay. Yeah, the many, particularly those with severe pH and grossly dilated pH can compress left main.
Yes, sir.
The aortoarteritis also you brought in under differential diagnosis. That can that fit into this? Breathlessness, orthopnea, I mean PND and chest pain.
Yes, sir. Sir, actually, patient is young female, less than 40 years of age, with sir predominant dyspnea that might be because of sir hypertension related, and there might be in some cases, in 5% cases, coronary involvement also in aortoarteritis that might contribute to angina, sir.
Is there any name given for right ventricular angina? Any name? Right one.
Okay. No, sir.
Okay.
Sorry. Yes.
Dr. Praful and Dr. Justin. Yes.
Yeah, we can go ahead now.
Yeah.
You entertained this thing. ASD Lutembacher syndrome, you said, right?
Yes, sir.
Suppose I grant you, how is the heart failure occur in ASD Lutembacher? Do you get PND or orthopnea as symptoms at all? What is the sequence of congestive symptomatology? What comes first?
Sir, it depends upon sir size of the ASD, sir. If it is restrictive ASD, then we can get sir history of PND. But if it is not restrictive, then PND is unlikely, sir.
So you can get RV failure symptoms first. That is the more important.
Yes, sir.
Because it will decompress, not the entire LA into this thing through a large ASD.
Yes, sir.
Yeah.
And
Okay.
aortoarteritis, have you ever seen aortoarteritis just presenting with these symptoms of dyspnea and angina? You must have seen many patients, right, Lucknow?
Yes, sir. Yes, sir. Yes, sir.
So you get a patient with this prolonged and no other symptom, just two symptoms, dyspnea and angina?
No, ma'am, it's unlikely. But I have not seen any patients sir like that. But
why did you keep this? I mean, theoretically, you may be able to explain, but why did you keep this differential? And idiopathic PAH, like how does it present? With a history of 8 years of dyspnea? What is the progression, natural history of pulmonary arterial hypertension? Idiopathic. How do they present?
sir, they present with RV failure. Ma'am, they present with RV failure basically.
And this 8 years, what is the like this? There's a natural history, right? From class 2
Yes,
to
ma'am.
class 3, you said it took 8 years. Do they present like that? How do they present?
Ma'am, actually 80% of them will die by second decade.
This is not the progression. So last 3 diagnoses are just kept for being kept. I mean, I don't think any of them will present, will be differentials for your history.
Yeah, Dr. Smarak, you are blessed with the history of rheumatic fever in this case.
Yes, sir. Yes, sir.
So in absence of history of rheumatic fever, okay, you could have entertained 2-3 more additional differential diagnoses. I think when the history is so typical, I think you have to stress on the rheumatic heart disease only.
Yes, sir. Yes, sir.
Because PPH, when once you make a diagnosis, the survival is 3 to 4 years, majority.
Yes, sir. Yes, sir.
Okay, we'll move on. The other thing Dr. Praful was asking between ASD Lutembacher versus isolated MS. So
Yes, yes, sir.
So is Lutembacher is a possibility here?
So if it is restrictive ASD, then it can be, sir.
Restrictive ASD doesn't come under the definition of Lutembacher.
Yes, yes. So less likely then. Yes.
So you are thinking of MS or MS with AS or MS with MR. So
historically, what do you think?
So historically, MS plus AS likely.
AS, is there any history of syncope?
No, sir.
Which one is predominant? MS with AS.
How often you see this combination MS with AS?
Sir, among the rheumatic heart disease, 2.3%, sir. Around 2.5%, sir.
That is the least common, right? Combination.
Yes, sir. Yes, sir.
Okay.
Okay.
Do you have to include mitral stenosis, or can you explain the symptoms by isolated aortic stenosis alone?
So long duration is going against isolated aortic stenosis because sir 50% if the dyspnea is predominant and it is systolic dysfunction, then 50% will die by 2 years of age on an average. So 8 years history is unlikely, sir.
Right.
Okay, we'll move on.
Go ahead with the examination.
Okay. On general examination, patient is conscious alert oriented. There is no pallor, icterus, cyanosis, clubbing, edema, and lymphadenopathy. Normal temperature, respiratory rate is 18 with an abdominal thoracic pattern. Pulse rate is 82 per minute, regular in rhythm, low volume, slow rising, no radial, radiofemoral delay, normal condition of the arterial wall, all peripheral pulses are palpable. Blood pressure is 110 per 80 millimeter mercury in upper upper arm, and the systolic blood pressure in lower limb is 130 millimeter mercury. JBP is not elevated with normal weapons, normal respiratory variation, and hepatoscopy reflex is negative of a normal response type, and there is no stigmata of infective endocarditis. Coming to cardiovascular examination, on inspection, the chest is a normal shape and bilateral symmetrical. There is no pericardial bulge. Apex impulse is visible in the fifth intercostal space in left midclavicular line. No suprasternal or epigastric pulsation. No scar, sinuses, or dilated vein seen. On palpation, the inspectory findings were confirmed. Apex beat is palpable in the fifth left intercostal space at midclavicular line. Localized tapping in character. Grade 3 parosteal heave is present in left fourth and fifth intercostal space. Palpable sound is present in left second intercostal space. There is a presence of systolic thrill in right second intercostal space. Bilateral carotid shudder is present. Apical delay is present, and epigastric impulse is felt, which is of RB type. On percussion, left hydrobladder corresponds to apex. Right hydrobladder is at the right sternal border. Left second intercostal space is resonant. On auscultation, S1 is loud, S2 that A2 is soft, and P2 is loud and splitting paradoxically. There is no S3, S4 heart. Opening snap is present. A low pitch mid-diastolic rumbling murmur with pre-systolic accentuation present at apex, base start with the bell of the stethoscope in left atrial position, and a mid-systolic pulse with late peaking, crescendo decrescendo, grade 4 murmur, base heart at the right second intercostal space with diaphragm stethoscope in sitting linear product position at end expiration, and decreases with Valsalva hand grip. A high pitched blowing pansystolic murmur of grade 3 intensity, heart in the left lower parosteal area with diaphragm stethoscope in supine position. Other system examination were within normal limit. So this is my final clinical diagnosis. Valvular heart disease of rheumatic etiology with severe aortic stenosis and severe mitral stenosis and moderate tricuspid regurgitation with severe pulmonary venous hypertension and severe PAH. Currently in NIHA class 3 in normal sinus rhythm with no evidence of infective endocarditis or CCF or acute rheumatic fever at present.
How much was the blood pressure, please?
110 by 80, sir.
180.
110 by 80.
Pressure is 110/80. Why do you say mitral stenosis is severe?
Sir, from history, there is history of a PND with a long duration of history, and from examination, sir, S1 is loud.
PND is severity criteria for mitral stenosis. Do you think only severe mitral stenosis can have PND?
Sir, please repeat the question, sir. Sorry, sir.
Why do you say severe mitral stenosis in this patient? What are the hard findings of severe mitral stenosis?
Sir, in finding wise, it is a severe AS is the predominant, sir.
No. I think question is mitral stenosis. Okay.
Okay. Yes, sir.
The reason is you have not explained certain things which I was looking for. So what are the hard points you use in the clinical examination to identify severe mitral stenosis?
In examination, always you have to be coaxial with the examiners. Okay.
Yes, sir. Sorry, sir. Yes, sir. Sir, A2OS gap and
Yeah,
is
you're not
important.
talking about the A2OS interval at all. You picked up the clue well, sir.
A2OS interval, what it is what Dr. Saab is asking you, my dear.
So it is basically hemodynamical isovolumetric relaxation period.
Dr. Smarky, you just tell me, how do you assess severity of MS, mitral
Sir-
stenosis?
Yes, sir. Sir, in examination, sir, prolonged diastolic murmur, diastolic murmur is prolonged, associated thrill, and A2 gap will be narrow, sir.
No, thrill, we don't agree. Thrill and severity of MS. One we agree, a long mid-diastolic murmur. Okay, then?
Yes, sir. Then, sir, A2OS gap will be narrow.
Okay.
And, sir, associated features of severe PAH.
Okay.
And if there is associated atrial fibrillation also, it will be significant, but it is severity criteria is not.
What happens to A2OS interval when there is an associated aortic stenosis despite severe MS?
So it will normal or it will widen, sir, because LVEDP will be high. So it will prevent opening of the mitral valve. So it will be normal or wide, sir. It will never be narrow, sir.
Another thing you said, apical impulse is tapping. So what will
Yes,
be the
sir.
apical impulse in a case of MS with severe AS? You still get tapping or you still get a heaving apical impulse?
So heaving apical impulse is quite unlikely because LV is underfilled. Either we can get a prominent impulse or it will be tapping because.
I think suppose if you take LV pressure even in MS with AS, what
Yes,
will
sir.
be the LV pressure, LV systolic pressure?
So it will be high, 170, 180 in that range means it will not be masked, sir, in the presence of MS, sir.
When was the last time you felt a apicocarotid delay? In your 3 years of residency,
Yes, sir.
do you palpate apicocarotid delays, or just because it's an examination you did it? That is not so relevant here. What is more relevant is the 2OS interval that you have to tell us. Okay.
Yes. Yes, sir.
You really tell me now, do you really do that or what regularly? Apicocarotid delays to find out this?
Actually, we try to do it we generally do, but very difficult to appreciate. But sir, we generally do it, sir.
We'll be pardoned for not mentioning that also. Yeah. Okay.
And in this case, your A2 is soft, I think.
It is soft, yes, sir.
With that A2 soft A2, how could you see the A2S interval? Where did you auscultate? A2 is already soft.
And you said second sound is paradoxically split. What does it mean? What may be the LV, aortic valve gradient when split is paradoxical, or what may be the LV systolic pressure? There are some correlations between paradoxical split and gradients and LV pressure, LV systolic pressure.
Yes, sir. So gradient will be more than 100, sir. It will be paradoxical, sir.
What is paradoxical split itself? What is, how do you know?
So paradoxical split means, sir, we are on expiration, the sounds will be splitted. On inspiration, it will be single, sir.
So what is happening to your JVP? What did you say about the JVP?
Ma'am, JVP is not elevated with normal waveforms.
With normal waveforms, and you made a diagnosis of severe TR.
Ma'am, moderate TR I've mentioned.
P2 is loud.
Yes, ma'am.
And you have a pansystolic murmur.
Yes, ma'am.
JVP is normal, you think? Should be normal. And the other is the apex beat with this LV outflow gradient of 100. It's a tapping apex. I think these two findings are
contradicting.
Yeah,
Very much. Either your LV or RV, one of the ventricle will show its dominance. Your RV is failing, you are meaning by presence of TR, moderate pulmonary hypertension.
Yes, sir.
No EDM heard at all, is it? No early diastolic murmur heard at all?
No, sir. No, sir.
Okay. Let's move on to the
Yeah.
time.
ECG,
Any
X-ray.
clinic- Sorry.
Yes.
See, other thing in your diagnosis, you say you have written no acute rheumatic fever. I don't think
yes, sir.
that is relevant. Only you can say, what do you say? If, see, you have said no history of evidence of infective endocarditis or CCF or acute rheumatic fever. Do you
Yes, sir.
expect acute rheumatic fever with this established valvular heart disease? What do you call? Rheumatic activity, you can
Rheumatic
say.
activity.
Yeah,
Rheumatic.
rheumatic activity may be a better terminology rather than acute rheumatic fever. Okay,
Okay, sir.
move on.
Yes, sir. This is standard 12 lead ECG in normal sinus rhythm with the rhythm is regular with mean frontal QRS axis of around plus 60 degree with features suggestive of LA enlargement in the form of duration of PUF in lead 2 is around 3 small square, that is 120 milliseconds.
Describe serially. You don't talk about QRS axis before
Sir,
talking about P wave. You were just talking about QRS and then you're going to P. You always go in sequential order. Please go
yes,
ahead.
sir. Sir, this is standard 12 lead ECG in normal sinus rhythm with the mean frontal QRS axis of around plus 60 degree with the features suggestive of LA enlargement as evident by the duration of P wave in lead 2 is around 3 small square, that is 120 millisecond, and there is negative deflection, negative terminal deflection in the V1 of P wave. That area is around more than 0.04 millimeter second, and there is nothing in the P wave in lead 2 with feature suggestive of RVH as evident by R wave height in V1 is 7 millimeter, and there is also feature suggestive of LV hypertrophy as evident by the V1 voltage criteria, that is V2S height and summated of the V2S and V1 V5R is around 38 millimeter, and with LV strain.
So it supports your diagnosis or it is refutes your diagnosis? Tell us that. What features support your diagnosis here in the ECG?
Yes, sir. Sir, presence of RVH and LA enlargement go in favor of, sir.
RVH, how did you get here?
So RV hypertrophy, sir, in V1, the height amplitude is around 8 mm, sir.
Okay.
Yes, sir. And sir, left atrial enlargement, both are going in favor of, sir, metal stenosis. And
What
presence of,
basis did you call it left atrial enlargement? Looking at V2, V3, V4, there is M pattern. Is that what is of the left atrium? Or what does V2, V3, V4 show? V2, V3, V4. You said notches in the P wave or something, right?
yes, sir.
So where does the P wave begin? You have got a good arrow with you. In V2, V3, V4, any of the three leads you pick up and tell us where the P wave begins. What is so great? You just tell us, no, where does the P wave begin and where does the...
Sir.
The width of the P wave.
Yes, sir.
Where does it begin? So there is a U and P combined there, right? So where did you see the notches? I cannot see the notches in the P wave anywhere.
Sir, in lead 2.
Lead 2 may. Okay.
Some suggestion. Okay.
Achha, the
Yes, sir.
AVF is showing something here. Okay.
Yes, sir.
AVF at all, third and fourth beats. Okay, good. So there is left atrium enlargement. There is biventricular enlargement according to you, right?
Yes, sir.
And what supports AS? What kind of a ventricular enlargement is that?
Sir, it is concentric hypertrophy.
Yeah, in the absence of digoxin, that is like a strain pattern, no?
Yes,
Yeah.
sir. Yes, sir. Yes, sir.
Okay, go to the X-ray now.
Sir, this is chest X-ray PO view taken in full inspiration with minimal rotation, with both bronchial and abdominal cytosolitis, with LV type of apex, with cardiothoracic ratio of approximately 50%, with LA enlargement as evident by sir cardinal angle near about 90 degrees, and double density shadow is present in the right lobe cardiac border, and prominent left atrial appendage, and the main pulmonary artery segment is prominent, and there is a grade 2 PVH as evident by the presence of Curly's lines at the base of the lung field.
What is the pulmonary venous pressure?
Sir, a chronic case, it will be around, sir, 15 to 30, 25 to 30, sir. 25 to 30.
Only B lines 25 to 30.
Yes, sir, Curly's B line, sir. Yes, sir.
What are those actually Cardiac B lines?
Sir, these are basically interseptal interlobular edema, because these are the horizontal lines present at the base of the lung field, perpendicular to the pleural surface. Pathologically, it represents the interlobular septal edema.
What about aortic shadow, aortic root? See, you just tell us what will be the aortic root in rheumatic case versus bicuspid aortic stenosis.
Sir, in bicuspid aortic, it will be dilated. In case of rheumatic, sir, underfilled, sir.
With your arrow pointers, where you will look for the aortic root?
Sir.
Okay.
Sir, here.
Okay, chalo. Next, show us the echo, because I think we'll otherwise run out of time.
5 minutes left.
Yeah,
Yes,
show us
yes,
the echo
yes.
quickly and tell
yes.
us.
Yes, sir.
Echo, please. Echo, please.
Yes, sir. Sir, this is the parietal long axis view, showing thick doming aortic valve, thick doming anterior metal leaflet with PM. The PML is restricted. Aortic valve is thick with LVH, LV hypertrophy, with LA enlargement. So this is the apical 5-chamber view, showing thick aortic valve with turbulence within the aortic root. And so this is the continuous wave Doppler across the mitral valve.
You have to tell us something more now over there. I was asking for AR, no?
Yes, sir. Yes, sir.
Was it there or not there? That color Doppler, when you say turbulence in the aortic root is not is the only thing that you want to say, no?
Yes, sir.
You want to say that the flow acceleration starts where? As also you want to tell us if there is any regurg or no?
Sir, according to the color flow, sir, here mild air might be present, but it was not present in the parietal long axis view.
Okay.
How can it not be present? So you did not get this regurg in parietal long axis? I mean,
So one.
Just-
Also there is a
huh? Just show your parietal long.
You have to run it and color
Yes.
frame you should run it.
Yes, yes, sir.
Okay. But anyway, okay.
there
They're
it
trivial.
was, no? वो
It
क्या
is
था
there.
नहीं था क्या था ना?
Hey,
Yes, sir.
Hey,
Trivial.
which is not good enough to be audible.
Correct.
Yes, sir. Yes, sir.
Okay. What else you would like to see and tell us?
Yes, sir.
This patient from point of view of interventions, because we now want to whether intervention or whatever, sir, whatever relief you want to give him, By that way, what measurements am I interested in and what you need to tell me more about the echo? You finished the echo, you may not have been able to document here for our sake.
Yes, sir.
Tell me everything that you would want to tell me about measurements wise.
So measurement we have to quantify the severity, sir. Then aortic annulus measurement is required.
So what is it? Tell us, no.
Yes, sir. Aortic annulus, actually, the slide is not there. So it was 28, sir. 28 mm.
28 mm.
I don't think so.
It is impossible to have that. You show that aorta long axis view that.
Sorry. No,
Is
no,
it
no.
28? Have you ever used a
23.
dilate that valve?
No,
What will
sorry,
you
sir.
do for this patient now, because we are running short of time?
Yes, sir.
What will you offer this? How old? 30, young lady, no? 33.
34, sir. 34 years.
Married.
Sir.
With pregnancies, you told us about pregnancies.
Yes, sir. Two living children there.
Fantastic. So
Yes, sir.
what will you offer for her now? Tell us.
Sir, double valve replacement will be suitable for her.
Why? What is the mortality of double valve replacement?
Sir, 9%.
So why not double valve balloon dilatation? Mitral valvuloplasty plus aortic valvuloplasty. Is it not possible here?
So already family is completed. So that's why we
Family
can-
is completed at the age of 33. You want her to give a double valve. What valve do you want to give?
So actually, natural history of double aortic, double valve valvuloplasty.
No. The
What is
question
there?
asked-
You know of any? Dr. Manjunath is sitting here. Double valvuloplasty nahi karega. Does aortic valve of aortic stenosis behave the same way in terms of its valve dilatation?
No, sir.
It is that what you say for aortic stenosis in the elderly, it's a different matter. You think about TAVRs and what you think now about
Yes, a bridge.
VDR.
Yes,
But
sir.
here, what double valve replacement? Why? What is the mitral valve score? Or is there any calcification there? Or even if you say OMV, AVR, to bhi chalega. But why are you talking about double valve replacement?
Correct. You did not show us the always short axis of the mitral valve will tell us properly how are the commissures.
Yeah, that's why I'm asking you what measurements you will give us. तो mitral valve का score दोगे, commissures कैसे है दोगे?
Yes, sir.
Now, Dr. Praful, what is happening? This younger generation orientation is towards aortic valve now, not towards mitral.
Mitral plus aortic, this is a classical case to do it. We've done so many, we unfortunately don't get them anymore now. And I'm telling you, I have people following up with aortic valvuloplasty, mitral, both done. I had promised last time I was an examiner somewhere, I promised to get reports to show.
Yeah, you just tell us, probably you may not be having those images,
Yes,
or
sir.
if the commissures are fibrotic or calcified, because of the parasternal lang axis, it was visible, I mean, they are calcified. But obviously, if they might, because commissure should be free from calcium to get a result.
Yes, sir. Sir,
That's
sir,
where
the
the balloon
commissures
works.
are calcified, sir.
Snap being there, no? And he's
Yes,
talking
sir.
about less being loud.
Tarak, I will ask one question. If commissures are calcified or if commissures are fibrotic, if leaflet is thin, body
Yes,
of the
sir.
leaflet is thin, if you
Yes,
do a
sir.
balloon mitral valvuloplasty, what do you expect?
Sir, commissural MR.
No, commissures are fibrotic, but
Okay.
the body of the leaflets are thin.
Then, sir,
Liquid
leaflet.
MR,
Cleft in the AML.
there will be a tear in the AML.
Yes,
Cleft
In fact,
AML.
that is one of the contraindication for balloon. Okay. So you feel it's a heavily calcified valve. See,
yes,
just
sir.
to, we are closing up. Can you tell what are all the echo scores used for scoring the mitral valve apart from Wilkins?
Yes, sir. So Wilkins score.
Apart from
lung, yes, sir. And then the lung score, sir.
You ask your colleagues because they have to support you.
Yes, sir. Yes, sir. Yes, sir. Lung score, sir. Lung score. Chain score. Read score. Global score.
I think they are not. You are not audible. Your friends are not audible.
Sir, the lung score, then chain letter score, read score, Mobius score, the commissural calcification score, sir.
No, you tell me a score where commissural morphology is also included.
The Sutaria score we use, but Marpol use Sutaria classification.
In Nasimuras and Carmier is subvalvular, okay?
Yes, sir.
Okay. So you tell us what do you advise? What do you advise for this lady of 34 years finally?
There was
So,
a lot of calcification, is it? What was the echo showing?
yes, sir. Yes, sir.
Yeah, calcified valve.
Where
Yes, sir.
calcified in the mitral commissures also?
Yes, sir. Tell with that picture we didn't have that short axis picture, but it was there, sir.
Okay, then no balloon dilatation. Then
Yes, sir.
Suppose if there is an appendage clot, valve morphology is suitable. Would you
Yes,
do
sir.
balloon?
So it depends upon the grading, sir. Sir, if the clot is according to sir proposed by you, sir, that if it is grade 1 or 2 way, then we can do, sir. If it is present above face of ovalis, then we can do, sir.